Re- Recording in progress.
Hello, Dr. Johnson. I am going to stop recording. Um, I can't hear you.
No worries, sounds good.
There we go. How are you?
I'm fine, thank you.
Hey guys, quick test of my audio.
Oh,
Sounds good. Hey, everybody, thanks for joining us. We're going to start in just a minute. Thanks for hanging out with us. We got a great presentation for you today. Hey, folks, we're just going to give 1 minute more before we start today. And thanks for joining us for GMN Insights. And so GM Insights. So looking forward to having a great conversation today. Thanks so much. And Stephanie, if you want to bring up your title slide, we'll be ready to go. Or if you want me to share the screen, I can do that too. Perfect. If you could flip it to presentation mode. And if you change your display settings, we're seeing your, yep. Just move over to display settings on the upper left. Perfect. Yep, there we go. We're seeing the right view. All right. Hey, thanks everybody for joining us today. We're really excited about today's presentation. It's Stephanie Vyverberg, APRN, NPC. She is a nurse practitioner, has been in the cognitive behavioral neurology program since 2008. She's also the clinical liaison for the cognitive empowerment program. She has oodles of experience today, and we're looking forward to her presentation about, hey, I'm worried about my memory, which is a common complaint and concern. Stephanie, the floor is yours.
Thanks so much, Ted, and thanks to everybody for joining us today and those that'll watch here in the future. Really appreciate the chance to share with you all on a topic that's near and dear to my heart, but also that many of you encounter, whether you're in neurology settings or primary care settings or other specialty clinics. As patients age, quite often one of their chief complaints is about their memory. And as we'll see here in our discussion today, sometimes it's memory. Sometimes the word memory can mean many different things. And so we'll explore how to kind of get at that chief complaint and how to work through it, and then what our responsibilities are in helping guide through the patients through that concern.
Hey, Stephanie, just hold on for 1 second. If you go back one slide, I think we're going to hit record. So hold on. Go back 1 slide, please. Thanks. And Emma, are we ready to record?
I believe it was recording when I logged in.
Yeah, and then I think we paused it.
Okay.
I'm sorry for the delay.
No worries.
Emma, thanks for just confirming that we're recording.
Yes, it is recording.
Okay, great. Hey, thanks so much. Sorry, Stephanie, for the interruption. Again, thanks so much for leading us in this discussion about, hey, I'm worried about my memory.
All right, so thank you all for joining today. We're going to be talking about patients who present with a chief complaint of memory loss and what that looks like in any setting where you may encounter it, whether it's primary care, specialty care, whether you're functioning in cognitive neurology or in a general setting, and excited to kind of give you some tools for how to navigate that. Wanted to start with basic accreditation statement for CME. You will be able to, at the end of the presentation, register for CME for this session today, and a disclosure statement as well. And I have no financial disclosures to share today. So wanted to talk through what we hope to gain from today's presentation first. As we already mentioned, as a patient presents with a chief complaint of memory loss or cognitive impairment, we're going to think about how to approach that patient. from various different angles and patient situations, as well as spending some time talking about the importance of cognitive screening, what are some key history elements that we want to collect in the evaluation of these patients, while also understanding kind of the scope of cognitive disorders, what key symptoms might give you clues about what you're looking at and what you might need to order, as well as diagnostic testing options and when to refer and when to treat and manage within your own setting, while also spending just a couple of minutes touching on some of the really critical community referral sources that might be helpful for both patients and caregivers who will need support depending on what we find when they come in with that chief complaint. So I want to start by talking about the importance of cognitive screening. There's been varied approaches to cognitive screening over the years and various perceptions of why it's important. And I think as many of us know, in the day and age where we now have the ability to potentially offer certain patients disease-modifying treatment that have the potential to slow their progression of disease through monoclonal antibodies like lecanemab and donanemab, and very soon when we'll have access to blood-based biomarkers that test for Alzheimer's disease, the importance of an early diagnosis and of cognitive screening has kind of come to the forefront. And depending on your clinical practice, a tool for cognitive screening can often be through the use of the annual wellness visit, the Medicare annual wellness visit. Cognitive impairment, while it can occur in younger stages, the folks that you most likely hear about that, hey, I'm concerned about my memory, can you help me out, are people who are going to be entering older age who have that front of mind because their friends are talking about it, or they're noticing some of that typical age-related change, like tip of the tongue forgetfulness, or I walked into a room and I don't know why I came in. But there are often people as they age that actually have true cognitive deficits, and we need to be able to detect those early, and the importance of giving them a clear diagnosis and a path forward can be really helpful. There are screening tools available, and many of them very practical for use in the primary care setting. The Mini-Cog probably being one of the quickest ones that involves a three-word recall and the drawing of a clock. But some people use an MMSE or a Montreal Cognitive Assessment. Any of these are appropriate. There are newer digital forms of some of these screening tools that are beginning to be available as well that make it a little more streamlined and easy to collect that data and upload it into your medical record system. And I often recommend, if you're able to also get a functional assessment questionnaire. It really helps you give a little more perspective on both the cognitive tests that you're seeing and how those match to that patient and how they're functioning day to day. I use the FAQ especially to get at milder symptoms because it gets a lot more at the earlier stage symptoms of things like maybe keeping up with current events or really complicated financial management, little things that start to come up that patients and families worry about. The Lawton-Brody IADL-ADL questionnaire will get more at basic ADLs, which may give you a little hint, especially for your more moderately to severely impaired patients. The other thing I want to mention is screening is important because oftentimes patients and families may not express their concerns overtly. Or if you're not paying attention, that care partner may be in the background going, not sure dad's telling the truth about his financial management this year. And if you're not paying attention and looking for that, you may not catch that concern, but they're afraid to talk in front of their loved one. And so it's really important to be watching for concerns and to be screening for those cognitive concerns in a objective way through one of these tests, so that in case they don't bring it up. A couple of other things that I find to be really helpful in my clinical practice and kind of tips or pearls are other signs to watch for. Probably my favorite is to pull up the patient's med list and start to go over it with the patient. I learn a ton about a patient just by going over their med list. And you can quickly pick up on potential cognitive deficits when that person either doesn't know what they're taking, has trouble telling you anything about their medications or what they're for, or really doesn't have, if they hand you a list and it's accurate, that's kind of reassuring. But it's good to kind of go one by one and ask them about their medication adherence and whether they're taking their medicine. Also gives a caregiver a chance to step in and say, hey, I'm kind of managing those. So that can be a nice little hint or clue. Another thing to watch for is if it's somebody you've always seen by themselves in primary care and all of a sudden now their daughter's coming along. It may be that you need to ask about cognition because, hey, I noticed your daughter's with you. Tell me about how you're doing with your memory and thinking. Those are some things that might come up. And then also monitor for changes in appearance or hygiene. Someone that was always kind of immaculately dressed that may be a little more disheveled or things like that. Changes in hygiene may give you clues that you might need to be more concerned than you had been in the past. And I think something that we really need to work on as a medical community as a whole is normalizing the importance of talking about cognition, talking about cognitive screenings, and emphasize the reason that early identification is important, because we now know that matching people to disease-modifying treatments early can really change some of their outcomes long-term, plus matching them to resources like lifestyle factors, prevention-based factors, exercise and diet, things like that. As I mentioned earlier, your patient may say, hey, Dr. Johnson, I'm worried about my memory. But what they might actually mean is, hey, I'm having a hard time coming up with words. And I used to give up and give talks in my business. And now when I get up there, I'm sweating bullets because I can't find the words. They may mean, I don't know how to work this dang new smartphone my kid bought me and used to. Technology came to me easily, or dad's now got 80 piles of papers in his office and he just shuffles through them all day long, whereas 2 years ago he did his taxes on his own and had no problem. So it doesn't always mean memory. It's a common term that people default to, but it's important to get at the type of cognitive loss that this person is reporting. Short-term memory often is, hey, mom's repeating herself constantly, or I called her about today's appointment and I came to get her this morning. She had no idea what was happening today. And so watching for, is it more amnestic and memory loss, or is it more of a language problem? Are they having trouble completing sentences? And you can pick up on a lot of those language deficits during your visit as well, just by listening to the patient, asking open-ended questions, and see how fluent their speech is compared to how it's been in the past. And then we've already also mentioned some of those executive functioning problems that might come up. Definitely things like following a recipe, using technology can be clues. It might even mean they're having hallucinations and delusional thinking, or that they're severely depressed. And so getting at a good history on, how are you feeling emotionally these days? Hey, I know this sounds funny, but any chance that you've seen things that other people don't see? Or ask a caregiver whether or not there's any paranoid or delusional thinking. If you don't ask, you won't know. And oftentimes patients and families won't reveal some of those more atypical symptoms, either because they're embarrassed or they don't think it's part of the problem. So this slide really kind of gives you a sense of some of the things family might tell you. You'll notice kind of in that bottom left corner of the right-hand side of the slide, it might even be some Parkinsonism or changes in gait. But a lot of these diseases that we treat have overlapping symptoms with Parkinson's disease. They may affect balance and gait. They may affect behavior. And certainly can cause things like hallucinations and delusions. And so these are just some of the common things to listen out for as you're in practice and patients are presenting in your clinic. I want to point out something that I think is incredibly important about how we look at these cognitive disorders. I don't know how many of you have either heard or said, it's not Alzheimer's, it's just dementia, or it's just age. It's not really a disease. And what we have come to learn, especially as we look at the brains of people when they're done using them, as Dr. La likes to say, is that many times there is, and most of the time, there is a pathological cause to their quote unquote dementia, and that dementia is really an umbrella term. As you can see under the umbrella, the largest piece of that pie is Alzheimer's disease. And so the A word is a scary word, and it's not one that anyone ever wants to hear. And we spend time talking about what that diagnosis really means for patients and families and how it impacts them. But one of the things I like to say is that clarity is also kindness. And so identifying Alzheimer's disease can help people both with planning and understanding what's ahead and what to expect, but also with matching them to the right treatments. And so the most common thing you're going to see in clinical practice is Alzheimer's disease, especially in those over the age of 65. And even more common, I think the statistics last I heard for Alzheimer's disease in 85-year-olds is at least 50% of patients over the age of 50 or 85 have Alzheimer's disease pathology. Also commonly, we see vascular dementia and Lewy body dementia. I'm not going to spend a lot of time on late. It's a relatively new pathological diagnosis that's on the scene. But we also see frontotemporal dementia, which can affect behavior and or language, and Parkinson's disease dementia. And the only other thing I want to point out here is that there is often crossover between these disorders. And so in brains of people who have Alzheimer's disease, up to 50 to 60% of those patients will also have Lewy body pathology under the microscope. And so these patients who start out with an Alzheimer's diagnosis may develop Parkinsonism. They may develop some hallucinations. Some of those common Lewy body symptoms may emerge as their disease progresses. And that might hint that they have some concomitant pathology. That's relevant because you may be more careful about antipsychotic medications with them, Parkinsonian-inducing drug or Parkinsonism-inducing drugs and things like that. And then vascular dementia is often a mixed pathology as well, with both vascular and Alzheimer's disease. So as we talked about already, a functional assessment can really help you. And I think starting with functional assessments can be very helpful in the sense that we can really know where to start with that patient. So if they're already severely functionally impaired, their needs are going to be very different than those who are fully independently functioning, maybe even working still full-time. You're going to address those patients differently. And so you really want to start, what I often ask myself is, am I looking at a patient that's still really in that mild cognitive impairment stage where they're still functionally independent, or am I already looking at a full-fledged dementia? And that's going to be question one that I ask, and not to the patient, but to myself. And then I want to really, that will help guide whether or not I'm focused on the critical nature of an etiologic diagnosis and matching them to treatment, or in later stages, whether I'm going to focus more on that patient's care needs, on caregiver support, and whether or not their main felt need is that they're having some of these florid behavioral and psychological symptoms of dementia. So later stage patients, their family members, the patients themselves may need help with things like depression, delusions, paranoia, agitation. And while an etiologic diagnosis may be helpful, a lot of these diseases start to look the same in late stage. And so it may be a little harder to arrive at, is this Alzheimer's or Lewy body or vascular, or is it all of the above? And your focus on clinical management may be more geared toward managing their behavioral and psychological symptoms, giving caregiver support, giving them a pathway forward on how to get the support they need for resources in the community. As we've already mentioned, Alzheimer's disease is by far our most common neurodegenerative disorder. And so another approach that I use is that if I do think that this patient has cognitive impairment and that it's meaningful, meaning it's starting to impact their functioning and that it's beyond normal aging, I start with Alzheimer's disease as my presumptive diagnosis and work through other considerations and contributing factors. And that's what our next slide is really going to get at. Just taking a quick glance at the chat to make sure I'm not missing anything, but we'll address those at the end. Okay, perfect.
And maybe just a quick comment on what's going on in the chat. Dr. Birju Patel appropriately points out that cognitive screening is something that USPSTF does not support with either an A or B grade or recommendation. Center for Medicare and Medicaid Services talks about the fact that you're supposed to do detection of cognitive impairment and you're supposed to assess. And so I do agree that there's kind of like, are we case finding or are we screening? And so maybe I'll put that question most simply to you that way, Stephanie. When you talk about screening, are you talking about case finding? As a cognitive neurologist, you're often taking patients that are referred to you. But from a primary care perspective, do you have any thoughts about that?
I think it's a great point to bring up. And I would argue maybe for a both and approach. I really feel like as clinicians, when concerns are raised or when you notice some of those things we talked about early in the talk about the patient and the changes you're seeing either in their ability to manage their medications or their own history giving, that detection of concerns and an overall assessment should really be part of the trigger. But I think where we're moving in terms of recommendations, at least as cognitive neurologists, is that there is a place for cognitive screening, for objective cognitive screening measures to start to get at these cognitive symptoms before the patient presents with concerns or even with overt symptoms, simply for the fact that as disease-modifying therapy is trying to target the very earliest stages of disease, we may identify someone with mild cognitive impairment who has either subjective and or objective symptoms who might be candidate for new therapy. And then I think as we're waiting for the outcomes of preventive trials in the next 3 to 4 years, that conversation is going to continue to morph and change. Because if we get positive results from these preventive studies on these same drugs given to people who have biomarker positive Alzheimer's but don't necessarily have symptoms, we may very much want to be screening much earlier. Is that helpful?
I think that's very helpful, and I think that you're pointing out that the USPSTF can only comment on published studies and can only review the published evidence base. And to Birju's point about the 10 warning signs of Alzheimer's, which I encourage you to follow, attendees to follow that link and take a look at them. To that point, some of the 10 warning signs of Alzheimer's disease are very moderate to late, and some of them are early, and maybe 1 or 2 of them are mild cognitive impairment. You're trying to push us to finding earlier people. So appreciate that comment, and continue. Thanks.
Thanks so much. Great comments. So the reason for this slide that looks very busy is to really turn your eyes toward the top here. So if you're taking a patient that you're seeing in your office, the first question you want to ask is this normal cognition, or do I need to be worried that they have some impairments that are outside of their normal range for aging? And while more detailed cognitive tests and a history may get at some of that, my tendency is to go with, if you're suspicious and family has expressed a concern or patient has expressed a concern, it is important to continue to dig a little bit deeper. And so then you want to ask, are we mild or are we more in that dementia stage? And if we are mild, or even if we're in more impaired stage, is it Alzheimer's disease or is it not? And as we all know, it's most commonly going to be Alzheimer's disease. But when it's not, there's a whole host of things that it can be. And a lot of this you're going to pick up on in the primary care setting just by doing a basic medication review and a basic review of their current disease states, and even taking a glance at those depression scales and mood scales that we do. And so we have quite a few options for looking at depression, mood. Is there a metabolic problem going on? Quick glance at thyroid and B12 will at least give you a hint as to if that might be contributing. And polypharmacy is such a common thing that we pick up on looking at those anticholinergic drugs. Is this patient taking a benzo every day for anxiety and Benadryl every night to sleep? Are they on a bladder drug, one of these older generation bladder drugs that might be anticholinergic? Again, not always causative, but often can make symptoms worse. And so doing a quick review of those things can be really helpful at tweaking out what might be making their symptoms worse, especially in somebody you suspect might be kind of more on that normal side, to make sure you're optimizing their health and their medications. There are a handful of more degenerative syndromes that we can look at that present in various ways. And I'm not going to spend today's presentation doing a deep dive on all of these, but a quick understanding of, is this really an amnestic picture in some older adult who's gradually progressive, is going to lead you more towards an Alzheimer's disease, although we do sometimes see a language variant version of Alzheimer's. But patients who are starting to present with more Parkinsonism or hallucinations or REM behavior disorder where they act out their dreams, you might suspect Lewy body dementia. And then you've got your variants of frontotemporal dementia that can present, especially in somebody who's a little younger and having changes in personality or behavior or strong language symptoms. And you can read the rest of these more rare disorders. One I want to point out is normal pressure hydrocephalus. It often gets overcalled on MRI scans. Because there is such a prominent atrophy from the degenerative process of Alzheimer's disease, those ventricles look quite big. And so I will tell you that in my 16 years of practice, we don't see MPH very often. But if they're presenting with that triad of incontinence and gait disorder and cognitive decline that all started around the same time, and you see large ventricles, you also don't want to miss that. So just another one to point out. All right, let me advance the slides here. And so people often ask, what should I order? Especially if you're in primary care. You always want to do a neurologic exam, and obvious things that you're watching for are some basic cognitive losses. Doing some quick, the one I often do is give somebody a name and an address. I'll say John Brown, 42 Market Street, Chicago, and then ask them to repeat that back and ask it later to see if they remember. I'll do some basic calculations like how many nickels are there and then $1. Some basic cognitive tests, but then also just looking for any focality on exam, anything that might hint at more of a focal problem that's going on. And then also a quick history. Is this acute or has this been going on for a while? If it's gradually progressive, I lean much more towards neurodegenerative. I also want to get a feel for their behavioral and psychological symptoms. So asking about delusions, hallucinations, agitation, depression, anxiety, and sleep. Sleep can really tell you a lot about what's going on with the patient or what might be contributing to some of their issues. And the studies coming out on the relationship between poor sleep and especially chronic poor sleep and dementia onset are pretty impressive. And so if we don't ask, we often don't know about their sleep. And you often need an informant to learn about sleep. Because especially in my forgetful patients, they'll tell me, I can't fall asleep for hours. And the wife goes, oh, he's snoring after 5 minutes. And so it's helpful to have an informant when you're asking about sleep, as well as looking at gait and motor changes. I also encourage people, and usually this is embedded in your workflows, but doing a depression and anxiety screening will help you really understand how much that is tampering or flavoring the picture that you're seeing, or maybe contributing to their cognitive, or as a result of their cognitive losses, they may be depressed. And so lots of angles to look at those mood symptoms. We've already talked about cognitive screening and medication review and labs. I want to spend just a minute talking about neuroimaging. And one of the questions that I get a lot is, what do I do if I order an MRI and am I responsible for it? And so the answer that I give for that is, obviously, if you're the one ordering the MRI, by all means, if something acute is found, let's say there's a tumor, let's say there's a subdural, then it will be on the ordering provider to address that and either get in a referral, send the patient to the emergency room, do what they need to. When it comes to the more detailed analysis of what does this MRI mean for this patient, I believe there are some basic tips of the trade, and I do want to show you a couple of scans so that we can look at those. For some of the things to look for, especially because our radiologists don't always call atrophy like we would wish they would, or they may not pick up on some of the microvascular ischemic changes that we want to be mindful of. And so there's a few things to just be mindful of, especially if you're in the primary care setting, that can help guide your thought process. But if you're thinking you're going to go ahead and refer this patient for specialty care, then by all means, you can expect our cognitive neurology specialist, and especially within our GMN network, our trained team of specialists, and we do MRI reviews every week as a group to really look at these more closely. And so you're looking to rule out things. The other thing to do is educate patients that this MRI is going to help me in the diagnostic process, but I can't see plaques and tangles on a scan, and I don't necessarily need to keep doing scans to monitor your progression, but it's going to help me rule out other things that might be problematic. And it might also give me some hints at what's going on with your concerns. And really appreciate the folks dropping some of these anticholinergic burden scale resources in the chat as well. Just notice those. Ted?
Every once in a while, we find out from our Chief Health Information Officer here that they're adding and enhancing in the background, and I just encouraged Dr. K to send that to our Chief Health Information Office and see if we can get an integrated anticholinergic burden scale into our chart. These tools are helpful. Thanks.
They absolutely are, and really appreciate that comment. So important. And families often come, even today, somebody said, I just want to make sure all those medicines are mixing okay together because he's on a lot of them. And so always thinking about, and we had a great talk this past weekend at our primary care symposium on frailty and what do patients really need to be on in terms of their disease trajectory. Is this medication or this screening tool really going to benefit them if their life expectancy is only 5 years, and so on and so forth. And so I just really encourage us to, addition by subtraction is one of my favorite clinical practices. And so if I'm seeing a med list that's really heavy and a lot of drugs that aren't really benefiting the patient or may have anticholinergic effects, can we get rid of some things to help them? So let's transition quickly to a few other evaluation tools that might create confusion, especially if you're not living and breathing cognitive neurology like I am every day. I get a lot of questions about ApoE genotyping, and I will be honest that until the past year and a half, I never ordered one in my entire career, and neither did most of my cognitive neurologists that I work with. Reason being is that it's not diagnostic. So it may give us some clues about the risk because it is a high risk. So those with ApoE homozygous 4/4 are at a much, much higher risk of developing Alzheimer's disease as they age. But it doesn't, if it's a patient with some mild symptoms, it doesn't confirm that they have Alzheimer's disease. And so we haven't really used it as a diagnostic tool. However, in the past year and a half, we've ordered more ApoEs than we ever have because it is a direct predictor of risk of the ARIA, which is age or amyloid-related imaging abnormalities that we see on MRI scans of patients that go on lecanemab and donanemab. And so those with an ApoE 4/4 status are at increased risk of side effects from these drugs. And so we have to have a really straightforward risk-benefit conversation with those folks. And so we've been running that test on patients who we think were going on disease-modifying therapy to have the risk discussion, but not in terms of a diagnostic workup. A metabolic PET is another one that's been used historically, and it is insufficient for confirming diagnosis. So this is a radiotracer uptake that looks at brain activity. It does not look at amyloid. That's different than an amyloid PET. And the time I use this, we actually reviewed one this morning on a patient, is to distinguish between similar disorders. And so if a patient and you're wondering between, is this Alzheimer's disease or frontotemporal dementia? So let's say it's a young person with language dominant and their MRI really hasn't shown much atrophy yet, and you're not clear whether or not this is FTD or a language variant of Alzheimer's disease, we'll order a metabolic PET for that, but not really commonly used in daily practice, and certainly not something that we'd be recommending in a primary care setting. It's more of to help tweak out which diagnosis is responsible for patients who have atypical symptoms. The lumbar puncture we use quite often, and it's still been kind of our gold standard in cognitive clinic for diagnosing Alzheimer's disease. And it's the sensitivity and specificity on this is quite high for both ruling in and in some cases ruling out. And so if it's negative and you've got high amyloid and low tau, and it's fluidly negative, that patient does not have Alzheimer's disease. If your amyloid is low and your tau is high, that patient pretty confidently has Alzheimer's disease. Those that come in an indeterminate range are a little more challenging, but for those that are either positive or negative, it can be very helpful in confirming diagnosis. And it is one of the required tools for putting patients on monoclonal antibody therapy. So either a lumbar puncture for Alzheimer's biomarkers or an amyloid PET is necessary before you can put a patient on drug. Down the road, these drug companies and the FDA will be looking at whether or not we can use blood-based biomarkers in the same way. But right now, the way things stand, these are the two diagnostic tests that are required before a patient can go on drug. And I did mention those plasma biomarkers that are coming. They may be sufficient to confirm diagnosis, and we're starting to use them in the cognitive neurology setting. I predict that we'll be using them more in the primary care setting in the very near future. But we want to equip primary care providers with how to use these. And so until they're widely available and until we do some more study, I'm not recommending these be drawn in the primary care setting unless a provider has a lot of ease with that. And sometimes your patients are going to walk in with these results because they're commercially available. So just be aware of that. They are matching quite nicely with PET results. And so I think they're going to perform quite well in the clinical setting. Let me check chat here really quickly. All right, great. Moving ahead, I want to spend just a minute or two looking at neuroimaging. So I know this is not necessarily an interactive session, but feel free to drop in the chat as you're glancing at this scan. And so for orientation, you've got your T2 flare over here. We use this more than anything to look for microvascular ischemic changes. But we can also look at brain volumes. So as a cognitive neurology team, one of the things we're always looking for is this a nice full normal appearing brain, or is there some atrophy? And then also looking pretty closely for microvascular ischemic changes. And then on the right here, you have a T1 axial, which atrophy is going to look a little, the volumes are not going to look quite as full on these T1s as they do on the T2s. But we're also looking at coronals, and this tiny structure here that you see, I always like to tell patients, it kind of looks like a little tadpole sitting in a hole there. Those are your coronal views of the hippocampi. So medial temporal lobe, hippocampi, and entorhinal cortex are really where we're focusing our energy to try to understand whether or not there's Alzheimer's disease, potentially pathology going on. So anybody want to guess as to whether this is a normal or an abnormal scan? And I don't need you to answer out loud, but feel free to drop it in the chat. And I will just go ahead and tell you this is a normal scan. So pretty full volumes. Those hippocampi take up a good amount of space. There's nice occupancy there. Not seeing a whole lot of microvascular ischemic changes. White matter disease is another way that we call that. Now I want to point you to some abnormal findings that are important as we think about degenerative diseases and cognitive impairment. And so this first image, and my arrow needed to be bigger to point all the way across, but all the white that you see here are pretty, what I would call at least moderately severe microvascular ischemic changes. I like to tell my patients, the same blood vessels that feed your heart feed your brain. And so over time, things like high blood pressure, high cholesterol, diabetes are going to contribute to the blood flow to the deeper parts of the brain, or the lack of blood flow. And so you see these microvascular ischemic changes, and you often can see these patients presenting with kind of a mixed vascular picture alongside their Alzheimer's. So these folks may be apathetic, they may be slow to come up with words, they may have slowed processing speed. And the more we learn about kind of the vascular hypothesis behind some of these neurodegenerative diseases, vascular changes can really be a precursor to these more degenerative diseases like Alzheimer's disease as well. So if you're seeing this, you're certainly going to think about coexisting vascular pathology in a patient. Here in the middle, we're pointing at those lovely hippocampi that in the last slide you saw quite full. Now you have to squint to find them. And so this is a patient who had a diagnosis of lumbar puncture confirmed Alzheimer's disease. And before we ever did their lumbar puncture, we had a pretty strong suspicion that this was Alzheimer's because they had pretty focal bilateral hippocampal atrophy. And those mediotemporal lobes, at least on this cut, aren't too much atrophied, but they're smaller than we would hope. And so you're seeing that classic hippocampal atrophy in this middle slide. And then on our last one here, I never really spent a lot of time on these sequences. This is our SWI sequence until recently. And the reason that this scan is so important is that these are microhemorrhages. These are the microhemorrhages that you don't want to see if you're considering putting a patient on lecanemab or donanemab. And so if a patient has more than 4 microhemorrhages, they're not a candidate to go on these disease-modifying therapies because they're only likely to have many more. and also some of that edema that we can see, that inflammation from the side effect of the drug. Ted?
Nope, we're doing great. This was particularly helpful for this normal and abnormal. If you could just run us through a slide or additional one in the last minute, that'd be awesome.
Perfect. Yep. So gonna wrap it up here. So 1 or 2 more comments are when to refer and when to treat. And so those patients that really have early onset and are presenting with classic symptoms or even atypical symptoms that you're concerned about are always appropriate to refer to try to get a clearer answer, especially people who might have questions of genetic history. People who are in early stage and might be candidates for early monoclonal antibody therapies, and then those with an unclear diagnosis or atypical features, especially if they're in early stage, are very much appropriate to either refer to specialty care or a GMN. I want to encourage in primary care that if patients are already in moderate to late stage and they have manageable behavioral symptoms, that getting an MRI to rule out something else like tumor or stroke is helpful, and some basic labs, but these patients can be managed in the primary care setting. Then bringing patients back for long-term maintenance post-diagnosis. We have other talks on GMN sites about how to manage some of the more problematic behavioral symptoms of dementia, but I have found that my partnership with a lot of our primary care providers really results in great outcomes for these patients, especially if they're connected to community resources as well. And then obviously for those that have really challenging neuropsychiatric or behavioral symptoms that aren't being responsive to basic treatment, or severe resistant to treatment depression, they're good ones to refer to psychiatry as well. So I have some other slides on resources for caregivers that we can go over, but I'll skip the part on some of the treatments and just close us out with a quote from the late Wright Kaufman that passed away not too long ago. I think this perspective as you walk in the room is the most important one. Amongst all the important medical knowledge that we've gained today, hopefully we all take away that each patient is someone's mother, father, spouse, child, or sibling. We want to respect them as if they were yours, look at them in the eye and listen to them and listen again. Laugh with them when you can, and likewise commiserate with them in their sorrow and their anxiety, and always be honest, but with compassion. Say you're sorry when you should be, and treat them all with respect and honor and professionalism. It's certainly been my pleasure and honor to follow these patients for as long as I have, and appreciate everyone's interest in bringing our best selves to these families as they face a disease they never wanted. So thanks so much.
Hey, thanks so much, Stephanie. I appreciate folks and their engagement and their questions. And you alluded to the fact that many of these recordings are available on the Georgia Memory Net website, as well as on our YouTube channel. So I encourage you to go there. Stephanie, if you could advance to the feedback slide, please, that'd be great. And so that last one more. And one more. And okay, so we might not have, there we go. So if you want to take a picture of that QR scan, that would be great, and welcome your feedback. Again, if you are signed up in Emory CME, you can text today's session 18060, and the phone number I'll put in the chat. It is, sorry. I'll put that in the chat as well so you have it handy. Thanks so much. I know some of you might wait a bit more on this call to get your credit as well as complete your survey. So thanks so much. We'll keep this classroom open for just 1 second more. Thanks so much. And thanks, Stephanie. Really important, useful information. Appreciate your coming on today.
Thanks so much, guys. Really appreciate it. Happy to hang on for a sec if anybody has questions. Dr. Patel would not recommend plasma biomarkers for primary care at this time. Couldn't agree with you more. Exactly what I was getting at. Wanted to make everyone aware that they're on the horizon, but I don't think they're ready in the primary care setting at this time, but wanted to make everyone aware of the hard work that's being done within cognitive neurology and in research to better understand how they perform, so that'll inform the future of how they're used in primary care.
Coming sometime soon. Is when we did have a topic for GM Insights on plasma-based biomarkers, and decided to pause it just a little bit, both speaker availability and timing of the topic.
Yep, absolutely. And just one other comment there is that you will start to see them since they're commercially available. So I wanted to make sure to mention them on the horizon, but not necessarily something we're recommending people use.
Hey, thanks so much. We're going to close the classroom now. Again, thanks, Stephanie. Really appreciate you. And thanks so much for coming, everybody.
Thank you all. Appreciate it.